Hi, I'd like to thank you all for taking the time out of your busy day to watch this. I'll try and keep it comprehensive but concise. It's intended for all team members, clinical and non-clinical. And whilst it'll be a little bit of a gallop through slides, and I won't be dwelling on each slide individually, if any of you wanted a copy of the slides to use as a learning resource, I'd be really happy to share them. Most of the slides contain details of the evidence I'm using to back up what I say. A little bit about what I'm going to talk about today. I want to talk a bit about our project, who's involved and what we're up to, for those of you who don't know. A little bit about deprescribing, what it is, what it's not, why it's important, who can do it, and why perhaps we're not doing it as well as we might be able to. A bit about the palliative care register and who might benefit from being on it, and the discussions about advanced care planning or deprescribing that result from that. Tools to support deprescribing process and the evidence behind some specific drugs. What we'd like to do with our project is to have, by the end of September of this year, all patients on the palliative care register in the 4 Symphony surgeries in South Somerset West PCN to have the opportunity of a deprescribing conversation with a trained healthcare professional sometime between their palliative diagnosis and their death. Who's involved? For those of you who don't know me, I come from a GP background. I still do a day a week at Martock or Petherton, but I spend the rest of my working week working with the community palliative care team, St Margaret's Hospice, Yeovil. Zoe Turner and Kate Jones have been instrumental from the very word go, as have the 4 lead GPs for palliative care at the 4 surgeries, Sarah Hutchins and the health coaches, the pharmacy team and the IT team. So what's the evidence? There's lots of evidence to say that there is a problem. First paper I've talked about here looked at polypharmacy in the palliative care setting and noted that patients took an average of 10 medications at death, and almost a third of them took 15 or more medications. This might come as a surprise to some of you and possibly not to others. The second paper was a large Swedish study. They looked at more than 150,000 patients who'd already died and saw that preventative medicines, things like antihypertensives, anticoagulants, statins, things that we might think about deprescribing, were continued frequently right until the end of life. And older patients with poor prognosis cancers were just as likely to be taking these medications. This review article looked specifically at the palliative cancer patients. So patients we really would be thinking that deprescribing would be looked at quite sensibly. But 20% of these patients were taking what they described as a potentially inappropriate medication. So a prophylactic, preventative type medication that was doing them no good at this time of their life. This is some qualitative research from America looking at patients' attitudes towards deprescribing, and it says that we as clinicians should be reassured that the majority of older Americans are open to having 1 or more of their medicines deprescribed. This is a definition of deprescribing that I've taken from this systematic review. I think it sums it up quite succinctly. Deprescribing is the process of withdrawal of an inappropriate medication, supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes. Underneath is a bit of an add-on to say that it's not a downgrade, but rather an optimization of care and an attempt to reduce adverse outcomes and increase quality of life. So that is what we're aiming for in this palliative care population, in the patients on our registers. Just to add on, we all know this anyway, but I think it's just important just to reiterate it. What deprescribing is not. It's not about denying medicine to anybody who'll benefit. Who can do it? Lots of you, I'm sure, are already doing it. Some of you might be thinking about doing it a bit more, hopefully. It's any trained healthcare professional who has the ability and confidence to discuss the risks and the benefits of a medication with a patient and or their family and come to a shared reversible decision. I'll talk a little bit more about that reversibility later, and the importance that these decisions don't need to be set in stone, and if a medicine is deprescribed and a patient feels worse for it or worried about it, it can always be restarted. Why do it? I'm sure lots of you will know the benefits of it. It's been shown in numerous, lots and lots of evidence to show that we notice increased cognition, appetite and taste. Medication compliance is better when patients are taking less medication, and we're looking to reduce side effects, drug interactions, tablet burden, falls, and ultimately admissions, mortality and morbidity. So lots of evidence to say that it is a good thing. And it goes towards a better quality of life, what we're all aiming for in our patients, not just our palliative care patients. Also, it has to be mentioned, there are financial implications for the NHS. Unnecessary prescribing is expensive as well as harmful to our patients. So, why don't we do it? Patients want us to do it. It's a good thing, but there's lots of evidence to say we're not doing it very well. What's the problem here? And this is a systematic review which looks at the barriers and the enablers to deprescribing in patients with a life-limiting disease, so in our group of patients. These are the clinician barriers, and I think a lot of them will ring home to us, really. There's a lack of clarity over who should be doing it. We're not always sure why it was started. We feel uncomfortable about stopping something that was started by someone else. We're always concerned about doing harm. We perhaps are concerned about the legal implications of deprescribing. We're concerned about what patients or families might think about this. And it goes without saying, we are all under huge workload and time pressures, and there's always lots and lots of things for us to do and think about. There are patient barriers as well. They might be worried they wouldn't be able to restart it. They might worry what their doctor would think if they start saying, I want to stop some of my medicines that you'd started for me. They might worry about healthcare professionals abandoning them or relapsing in their condition, and deprescribing perhaps not being such a good idea for them. Just because I mentioned the legal implications, deprescribing is legally the same as prescribing. We have a duty of care to cause no harm and to obtain informed consent. This complies with the 4 pillars of medical ethics: beneficence, non-maleficence, autonomy and justice. And again, don't forget reversibility there, especially when it comes to deprescribing. I wanted just to take a moment to talk about the palliative care register. The numbers on the registers at all 4 of the surgeries don't match the national expected prevalence. And so we have to conclude that there are patients not coded on our practice lists that should be. And so I think what I wanted to talk about is why code someone as palliative. There's benefits to the practice and to them. They're discussed at an MDT setting. They would have more of an opportunity of deprescribing or advanced care planning conversations through that GSF meeting. I think it's so much more straightforward with cancer patients. They see their oncologist, who sadly says there's no more treatment options. And so they get transferred into palliative care and thus get coded. What's harder is patients who are more frail with lots and lots of chronic diseases. And it's difficult to really judge when we say we would not be surprised if they were to die in the next 12 months. And I wanted to bring your attention to Spect. I've got a photo of it on my next slide, hopefully. This is just to show you what it looks like. This green version is Spect for all. So it's actually for patients, families, and nursing home staff. There is a blue version that has more clinical jargon on for doctors and nurses if they want that. But the top of it just talks about whether people have signs of poor or worsening health, and whether they've got any specific conditions there mentioned in the middle that really might show you in combination that that person's health is deteriorating and might make you think that, yes, I would not be surprised if they might die in the next 12 months, and maybe they should be on the palliative care register and be included in those MDT discussions where advanced care planning on deprescribing would be discussed. Just to mention codes and which codes to use, there's lots of codes on EMIS. There is generic sort of palliative care is a code, or more specific end of life care when they're right at the very, very end. The GSF codes, the colour codes, green, red, are more advisable, I think, going forward if we're unsure of what to use, because those are codes that we will be able to search for going forward and show not only that we're doing a good job by these patients, but that we can prove we are as well. That's the Spect. Other tools that might help us, I've mentioned Spect. Numbers needed to treat, numbers needed to harm. There's a slide there that shows what that website looks like. I'm sure most of us have used it before, and there are patients who really get on with data presented that way. There is a tool called OncPal, which I'll talk about in a minute, the 5 steps to deprescribing, and Stop Frail and Beers, which are more for the frail elderly population that a lot of us see very, very often. This review article looked at deprescribing in palliative patients with cancer and did a review of the tools and guidelines. So, and mentioned in summary, really, that in those palliative cancer patients, they would recommend a combination of these 5 steps to prescribe and the OncPal guidelines. So these 5 steps are looking at the medicines, considering their indications, benefits and harms, looking at which drugs you might deprescribe and implementing a plan. The OncPal guidelines, the next 2 slides, I've sort of chopped them in half so you can see just how they're laid out, really. They're laid out in a table form in sort of medication classes, cardiovascular system there, and in the bottom, musculoskeletal, alimentary tract, and it talks about specific medications, consideration for limited benefit, and the explanation. So it's really very specific in the guidelines. If you're not sure, you can look on this table if it's a palliative cancer patient and look at whether perhaps the long-term benefits are suitable for our patient there. I've done similarly with the Stop Frail here, just to show you what it looks like. This is the top half of it. This is the bottom half of it. Again, it groups drugs into systems and is quite specific about which drugs are useful or not useful in patients who might die in the next 12 months. So in summary, how do we deprescribe? We look at, is the medication essential? Is it providing quality of life, i.e. symptom control, or is it a preventative type medicine? Looking at lengthening life. And is that what the patient really wants? Are they likely to live long enough to see the benefit? And if we're unsure about that medication, perhaps we would consider using one of the tools I've talked about today. Next step, we can deprescribe, reduce or substitute inappropriate medication. Always it's a shared decision. We review, we safety net. If we're unsure, don't do it. And just at the bottom, I've said there, remember the MDT. When I mentioned the paper earlier, the systematic review looking at the barriers and the enablers to deprescribing, and we talked mainly about the barriers, but one of the biggest enablers to deprescribing was the MDT. So if you're unsure about that patient, code them as palliative. They're then discussed at the palliative MDT, the GSF meeting with the team that knows that patient's best, and we can make a decision about whether a deprescribing conversation with that patient would be in their best interests. And I like to talk about a medication trial, a medication holiday. That's how I describe it to patients, the reversibility. Let's try stopping your statins. Tell me if you feel any better. Tell me if you're worried about it. A little bit about evidence for specific drugs now. This is a paper about statins, looking at adults with life expectancy between 1 month and 1 year. So our group of patients, they randomized them to 2 different groups, one stopping statins and one continuing them, and saw no statistical difference in mortality. Cardiovascular events were few and similar in both groups. It was an American study again, so dollars were saved and an increased quality of life was shown, decreased side effects, that kind of thing. So that just really shows that stopping statins in this group of patients is both safe and beneficial. This article I wanted to bring up because they discussed looking at deprescribing in quite a specific way. They looked at the remaining life expectancy of their patient. They looked at the drug and the likely time until that drug would have a benefit to that patient. They looked at the goals of care for that patient and then decided on treatment targets. And I wanted to bring this as an illustration, actually. This is not about a palliative patient. This is a 75-year-old lady with a life expectancy of 17 years, so very much not palliative. And they looked at her medication and they used her as an example. And they said that, you know, treatment of her hyperglycemia and hypertension with the medication she was taking, an ACE inhibitor, sulfonylurea, may show benefit on average after 10 years, which was when 25% of patients might develop proteinuria or renal damage. That was taken from the UK PDS trial. They looked at her statin, they said that might reduce her risk of cardiovascular events after 2 years and significantly reduce them at 5 years. And her aspirin would reduce her risk of myocardial infarction at 5 years. So for this lady with her life expectancy of 17 years, these medicines are highly appropriate for her. But I suppose I wanted to use it as an illustration to compare with our patients who have prognosis of likely less than a year. And so therefore, medications like this that take perhaps 2 years, 5 years, or even 10 years to benefit are not appropriate for our patients. And it would be a good way to explain it to them, that the time it's going to take for those medicines to benefit them, they're not going to live long enough for that to make a difference. Thank you so much for watching this. I hope you found it useful. Please, if you can, leave some feedback. There's a link on the same web page as you found this to a very brief questionnaire. I think it's 6 questions. Most of them have got self-populated tick box answers. It's a bit of feedback about this teaching, how the form it takes, and if you would like anything further, written information, resources or slides and things, and just a little bit of feedback about the quality improvement project and any ideas, any tweaks that would make a difference taking it forward. Thank you so much for your time.